Dr. Brad Gardiner. Dr. Brad Gardiner is an infectious diseases physician here and a clinical researcher here at Alfred Health and Monash University, and his research and interest focuses on the prevention, early diagnosis and treatment of infections in transplant patients. I won't go into too much info about Brad, but what I think is important is his talk actually follows on beautifully from Dimi's talk and Lucy's talk, and gives a bit more look at what the role infections play after transplant and rejection.
Well, thanks very much for the introduction. It's great to be here to talk today. So I'm an infectious diseases physician. I'm mainly a clinician. I see a lot of patients, a lot of referrals from the lung transplant team over the years. That's not all the patients, but the ones that I see are often really struggling with a lot of infections. They're in hospital for a long time. I have to give them antibiotics for ages that cause a lot of side effects. And so, I guess one of the focuses of my research has been to try and figure out, can we predict who's at risk for infections? And if we can predict maybe who's going to run into problems, we can try and prevent some of those from occurring in the first place. I guess what I thought I'd talk about today is sort of a brief overview of a few studies rather than a deep dive necessarily into any one or the other, and a bit of my journey through this. We see the full range, of bacterial, viral, fungal, and other exotic infections. Often these are serious, resulting in hospitalization. And, as we just heard, it's all about immunosuppression, right? You don't want too much, you don't want too little, but getting that balance right is very, very difficult. And it often changes over time. And so a lot of the immunosuppression protocols are just protocolized and responsive to, when someone develops infection or rejection, then that's treated. But I guess the idea is, can we do better? And can we use, all these new blood tests to try and figure out how to tweak the immunosuppression and who might be at risk for infection? And that's the whole concept of immune biomarkers, which are basically blood tests that can measure, the immune system a bit better. And one of the problems is it's really, really complicated, there's all this stuff going on. You've got all these different parts of the immune system. You've got immunosuppression and you've got infection, and it's very difficult to actually measure that, right? So there are all these tests now available, and some of these are more complicated than others. Basically, you've got some tests that are targeted towards CMV specifically, which is one of the really important infections, but it's only one. And then you've got these so-called global immune biomarkers, which try and get a better, overall measure of the immune system. And then you've got all these others. And then people have tried to put them together, which has been variably successful. And so what I'm going to focus on today is three specific ones that we've been interested in for many years now, and some of the studies we've done on those. So my journey at the Alfred began in 2017, and this was sort of the first project that I was involved with. Sort of a brief summary of 2 years of my life, and half of my PhD was looking at 263 lung recipients who had this quantiferon CMV test done at around 5 months post-transplant, and that was used to kind of try and figure out how much prophylaxis to give, and was that sort of helpful in reducing CMV. And basically, 50% of this cohort developed CMV infection at a decent sort of level. And the patients who were getting quantiferon guided testing seemed to have less CMV, but what we realized is that if you were, there were really important differences between whether you had CMV before your transplant or you got it from your donor. And essentially no one who was D plus R minus, like the highest risk group, developed a positive quantiferon while they were at 5 months post-transplant. And sort of unpacking that took a long time and a lot of work, and we figured out basically that if you got CMV from the first time from your donor, you were really, really high risk for CMV infection. And basically everyone developed some form of CMV, although that could be reduced by giving more antiviral prophylaxis. And eventually, we went from 5 months of prophylaxis originally to 11 months, and at the moment we give people often indefinite prophylaxis, although not everybody. And amongst the recipient positive group, which is actually the majority of patients, the quantiferon test couldn't really differentiate who was actually at risk of CMV infection, although again that benefit of extended prophylaxis was seen. So that the next study was involving this quantiferon monitor test, which again is commercially available. You know, we were doing it in the lab for a while. It's this general immune marker, and basically we looked at 80 patients and collected blood at these regular time intervals in the first year post-transplant. And I went through painstakingly and characterized all the infections that these people experienced in their first 2 years post-transplant. And basically what we found here is that serious opportunistic infections, which is not just CMV, but also like fungal infections, nocardia, cryptococcus, all the kind of complicated bad ones, basically we could identify who was at higher risk. So if they had a quantiferon monitor value of less than 10 at 3 months, they were 6 times more likely to get an opportunistic infection requiring hospitalization between 3 and 6 months post-transplant. And, you know, these infections actually affected almost half of this cohort, actually. And so this sort of test was of interest. So the next study really was to look in a bit more detail at those recipient-positive patients, which again I mentioned is the bulk of the cohort, and sort of really focus on 2 tests in this cohort, right? The absolute lymphocyte count, which I've had like an interest in for a long time now. It's a really simple test. Every patient who gets every time they get a blood test, we get this value. It doesn't involve Dimmy taking fancy stuff up to her lab and doing it and, you know, a month after the fact. You know, it's just there. It's available. It's very easy. And then because we had this data available on this other tube that was collected as part of that original study called the mitogen, I thought I'd look at that too. And I actually just presented this in Istanbul at TTS. And, you know, basically what we found was amongst these 204 recipient positives, 60% of them had a positive donor, 75% of them had a positive quantiferon. But, you know, half of them developed CMV infection, although it was a mixture. It was mostly in the lung, and it was mostly at a lowish sort of level. But one thing that we found is that, you know, those patients who had a positive donor, in addition to being positive themselves, were actually at much higher risk of developing CMV infection. And this is a really simple kind of risk stratification thing that we could do. And if that patients had a low absolute lymphocyte count, you could combine that information with the donor status and really risk stratify people into low risk, moderate risk, high risk. So for example, if you're donor negative and your lymphocyte count was above 1 at 5 months post-transplant, you're unlikely to run into problems with CMV infection, only 1 in 4, and mostly that's at a low level. However, if your donor was positive and your lymphocyte count was less than 1, you know, 3 times out of 4, you're going to develop CMV infection. And so this is a really simple, clinically applicable sort of strategy. And look, adding them, we also looked at the mitogen test, but it didn't really actually add much to these very simple, cheap, readily available kind of factors that we have. Unfortunately, we are sort of hopeful it might improve predictions, but it didn't seem to. So then the next study that we're kind of working on at the moment is I've gone back to that quantiferon monitor cohort, right? And that 80 patients in whom we already have all the infection data, we had blood collected, we had it all available. And I've gone and sort of added in additional tests, right? And I've got an honours student who I need to get a photo of actually and put up here, who's submitting his thesis on Friday. And basically we've gone back and added in the lymphocyte counts, neutrophil counts and mitogen to sort of figure out, can we improve predictions basically, and sort of looking at values at 3, 6 and 12 months and the infections that occurred in the 3 to 6 months after that. And again, the lymphocyte count really came out as being sort of the strongest predictor of opportunistic infection overall, many of which, but not all of which, were CMV. And adding those additional tests increased our predictive utility somewhat, but really the lymphocyte count was actually the best predictor. And there's a lot of numbers that back that up that I'm not going to show you today. So the whole idea is really, can we go from this sort of protocolized approach where we treat people the same and reactively to, can we use these immune biomarkers to sort of individualize, you know, what we do a bit more specifically. And I guess these are some of the impacts and outputs from this work. You know, we've published a lot of this. So there's a manuscript which Glenn's just tracked some changes on this morning. Thank you for that. That's coming. And you know, I managed to present this. You know, and this is all sort of in no small part thanks to the support from Lungitude Foundation. Got invited to write this review article, which got a bit of traction on Twitter, which was great. 5,000 views, although Glenn and Greg don't seem to be on Twitter. And then, yeah, it led to an invitation to participate in the writing of the 4th edition of the CMV International Consensus Guidelines, which were in Montreal in June this year. And some of these studies are going to be cited to support recommendations that will come out in the 4th edition of these guidelines. So, in summary, these immune monitoring assays have definitely improved our understanding of post-transplant immunity, infection risk, and are a step towards being able to better measure the net state of immunosuppression and hopefully identify so-called overly immunosuppressed patients who are at high risk for infection, which could inform real decisions like duration of antiviral prophylaxis, frequency of virologic monitoring, potentially immunosuppression management. We don't yet know how to integrate these into routine practice, and that's something we're working on at the moment. And, you know, can we combine these with other tests that perhaps are more useful in predicting rejection, which we don't want to forget about in all of this? You know, things like the EPLET scores, and then there's these new tests called cell-free DNA and some of the other complicated immune tests we've heard about today. And, you know, more studies are always needed. And, you know, more blood tests, more values, more outcome data. Yeah. So again, thank you very much. It's been a pleasure to continue to work with the lung transplant team, Lungitude Foundation, and, you know, thanks again to all the patients who've contributed to these studies, and hopefully we can continue to work towards, you know, improving infection-related outcomes in these in complicated lung transplant recipients. Thanks.